has acute injury ACL with this MCL injury. What would you do? You have to think. We have 7 options. ACL reconstruction and conservative for MCL, conservative for MCL, and then ACL reconstruction, ACL reconstruction and MCL reconstruction, ACL and MCL repair. So we have many options. What to do? So I think by the end of this lecture, we will know how to decide what to do. Now, again, graft choice. ACL, MCL. Would you take the graft from same side or other side, or choose quadriceps graft or PTP or allograft and foot repair? So, how to decide? Another question: repair versus reconstruction. When to do repair and when to do reconstruction. This is case. What do you think? Repair or reconstruction? You see, it looks like good material here for the MCLs about from the tibial side. What we call this? Who knows? Thinner lesions, thinner like the other collateral ligaments. So this looks good material for repair. Now this, repair or reconstruction? Because good material for reconstruction. So I'll provide you successful or steps for successful treatment of the collateral ligament injury. Step 1, knowledge, anatomy, biomechanics, because the MCL is not just simple ligament. It's a part of very complex capsule ligamentous structure. So it's important to know the anatomy, the MCL parts, the oblique ligament, the role of dynamic stabilizer, the role of each one, because we know each ligament there is muscle to protect. Yeah. So we have, if we, for example, implant a ligament, so we have to keep the muscles which protect this ligament. So we have what we call it static stabilizer and dynamic stabilizer. And we know that the MCL, the superficial part and the deep part, the role of them, which is primary, secondary, and also we have the dynamic. Look to how complex is this, the semimembranosus insertion. It's complex, yeah? So it's not a simple anatomy. And also we have the vastus medialis, the medial retinaculum, and the vis anserinus, we commonly use in the ACL reconstruction. So these are dynamic stabilizers we have to preserve. Now, this is a case for ACL. He has ACL and MCL, and we plan to do surgery. Why we prepare the other side? Who knows? To preserve the dynamic stabilizer. Yeah? Okay. Now, the lateral side, again, it's complex structure. Fibular collateral ligament, obliqueus, obliquiofibular ligament, and we have also dynamic stabilizers, the biceps, the gastrocnemius, tensor fascia lata, and so on. So we have to know these ligaments and the role of each one, even by clinical examination and the importance in later treatment. Now, step 2, proper diagnosis. Dr. Ziad told us history, clinical examination, radiology, yeah, imaging, MRI, but we can add even stress views, and also, one important thing, EUA, examination under anesthesia, always will add to your diagnosis. So, acute or chronic, this is by history, grade of injury, important, by clinical or stress views. You can see grade 1, 2, 3, what's this? Yes? We have to test clinical on full extension and 30 degree, and we know that this is basic. If it's full extension, it opens. This means that there is osteomedial capsular injury or cruciate injury. Now, also we have to know the site of injury. Is it different? Important? In MCL, for example? Yes, sure, because we know if it is in the femoral side, this causes less stability and even amenable for conservative treatment if isolated. While if it's here distal, this is cause very excessive valgus instability. So most of these distal avulsion needs surgical treatment because they are also part of other ligamentous injury. Also the extent of injury, and we have discussed that. What else? Associated injuries. So MRI will add to us information about associated injuries we cannot see. Like what? ACL, we can test it, sometimes deceiving in MCL tear. Medial meniscus, look here. Also osteochondral injury or chondral lesion. PCL injury, sometimes again by examination may be deceiving. And also patellar dislocation. And I'll show you a case where the MCL was associated with patellar dislocation. So, what's next? This is a case of mine, maybe 12 years ago. This is a football player. I did ACL for him, and he had NCL. And I treated conservative, and this is the result. I took him back to the theater. Yeah, we have learned from our practice. So you see, it's stable on extension, and it opens on flexion. Yeah. So unfortunately, I choose that. But I have learned from my practice and show you how I did modify my practice. Now, proper diagnosis, history, clinical examination, stress review, MRI, and examination and analysis. Now, step 3, treatment decision. You have knowledge, you have proper diagnosis, and you have to take your decision. Now the question, is it conservative or surgical? If isolated, low grade, most of the time conservative. If it's high grade, associated with other ligament injuries, mostly surgical. Now, if you decide to do surgery, repair versus reconstruction, who's with repair? Who's with the reconstruction? So each case should be individualized. This is the answer. Now, the indication for MCL repair, multi-ligament injury, distal avulsion, and we discussed that, entrapment inside the joint, because this is absolute indication for surgery, and continued instability after non-surgical treatment, like the case we showed. Now, augmented repair has better result than just repair. You know about augmented repair? Okay, I'll show you how we do this. Now the other thing, when to do reconstruction. So the rule is if you have repairable tissue, the best is to repair or to augment your repair. But if you have non-adequate tissue, so you have to reconstruct. So in these cases, when it's chronic or non-adequate tissue, you have to do reconstruction. Now, okay, we have the diagnosis, treatment decision, and we have to check something before we go to the theater. What's that? Associated injuries. This is very common in grade 3 MCL injury. And also, Dr. Hakim said, alignment. So we have to take care of the alignment. This is a case, and this is not traumatic, not sports injury. This patient has spina bifida. But this is very nice to show you that this patient has no trauma, but she has valgus and dynamic stabilizer dysfunction because of the neuromuscular problem, and she developed stretching of the medial collateral ligament. And if we do reconstruction, do you think this will be successful? No. So we have long film. Look here, we correct the deformity resulted from the MCL laxity, and we make planning for osteotomy. And look, osteotomy will relieve tension on the ligament and will relieve load on the lateral compartment. So this is important. So we did double bundled MCL reconstruction with osteotomy. Okay, now other principles, surgical principles. We are in the theater. We have to have principles how to treat these patients. What are the principles of augmented repair and what's the principles of doing reconstruction? Augmented repair. What's augmentation mean? Look, we can do it either, look here, by we repair the MCL and put like autograft to augment it. When the tension happened, it happened to the augmented ligament, not to the main ligament. This is can do by autograft, by synthetic material, which is this commonly used because we don't have to take a graft. Now, if any load here the repair side, the load would be taken by the brace. So this is important, protect your repair and also make rehabilitation earlier. So back to this case, stellar lesion, yeah? Look, this is after repair, just repair. Still some residual laxity, and here what we did bracing, internal bracing. And look here, it's like this. So this will protect our repair. This is another case. This is road traffic accident. Look, he has MCL tear and ACL. Now, what's next? Proper diagnosis. So this patient, if you see to the MRI, you see here he has MCL tibial side injury, and look here, what's the diagnosis? What's the diagnosis? MPFL. Look to the bacterial sublet. So this patient has MPFL and has ACL. MRI showed us other injuries. Look, he has ACL, MCL tear, partial ACL, NDFL tear, femoral side, and pocket handle medial meniscus tear. So we have to make our plan. This is our plan. MCL repair, augmented repair. Here, augmented repair. NDFL repair using the same anchor for bracing, cost effective. ACL reconstruction, medial meniscus repair, and the stability was good for LCL, so conservative for LCL. We went to the theater, make the tunnel here, common femoral tunnel, sorry, not tunnel, this is the real hole for the anchor. We use one anchor for medial meniscus, for the MBFL, and for bracing the medial meniscus. Now, look here, with the repair of the MCL, now we're testing its place, where to put the distal anchor, stability, and here we suture the MBFL. Look here, the patella is dislocating. Now look what happened if we tie the sutures. So we did the repair, followed the plan, and this is the result. After 10 weeks, he has stable ACL, stable MCL, and look to the patella, stable patella. So this is important, how to think of the diagnosis and how to plan your treatment. Now, reconstruction, which graft, which technique. The technique, we have numerous techniques for MCL. And there is lack of high quality literature comparing these techniques. But there may be principles, which I show you how we decide in the next cases. Now, which graft? Allograft, cementogenosis, well, I used all these grafts in my practice. But I found the allograft, Achilles is a good option because though it's expensive, because it's broad. The MCL is broad, so I like this. If not, I would choose Bible says, at least. If by double bundle, I would choose cementogenosis if I don't have allograft. Now, augmented repair versus reconstruction, there is not much difference. The only thing, if you put it only on the bone, by anchor, this is augmentation. If you repair, sure, if you repair the medial collateral ligament, and if you make a tunnel, this is reconstruction. So no difference between augmented repair and reconstruction in terms of biomechanics if you do early repair. Now define the technique. You have to know all these points. You have to have this picture, and I myself will review before I'm going. If long time I didn't do the surgery, I go back and review the points. So you have to know these points, where the origin and insertion of each ligament, and you have to decide non-anatomic or anatomic reconstruction. Look, if you want to do anatomic, it's like this. So this is double bundle anatomy, and you should know all these measurements or distances. Okay, so make a photo. Now, this is the either single bundle, anatomic single bundle, or anatomic double bundle. This is by examination. It's open in full extension, so there is injury of the osteochondrial ligament. You have to do double bundle. This is single bundle, double bundle, and this is. There is a modification. Instead of having double bundle with two femoral tunnels, you can do double bundle with one femoral tunnel, because you know the distance is close to each other. So maybe good. This is good modification of the technique. So this would appear like this, and this. Now look here. What's this? Who knows? This is for the deep MCL. When you reconstruct, if you don't put this anchor just below the joint line, maybe 1 centimeter below the joint line, this length of the ligament may slide on the tibia. So this provides very excellent stability. And if you do this technique, you will try up before and after, show how this will add to the stability. So this is important. This is the reconstruction. Now, what about the lateral, collateral, and postlateral coordinates? This was called the dark part of the knee. Difficult to treat, difficult to know the biomechanics, the structures. But now, with the improved knowledge about the anatomy and biomechanics, there is improved results of treatment of the postulateral coordinate. It's often with concomitant ACL and ECL injury, and can be missed. What's the problem? If missed, like if you have lateral collateral and ACL, and you did ACL, this may fail. So this is a cause of persistent instability and also a failure of other ligament reconstruction. So you have to have proper diagnosis. Principles almost the same as it's here. Yeah, knowledge, anatomy, proper diagnosis, stress test, MUA, diagnose malalignment and associated injuries, which is very common in skeletal corner, and do proper preoperative plan. Again, this is complex anatomy, and you know here we have the femoral. This is the fibular collateral ligament, obliques, femoral, and we have also the ALL. It's not part of the skeletal corner. Now, clinical test, you should know all these tests, how to do the test, and the meaning of each test, the result of each test. Now, let's take this case. All injury, football player has direct impact to the medial aspect of the knee, maybe 1 or 2 years before, and he presented to me complaining of instability. And look, he can demonstrate the instability. You see? Now, examination, he has instability, but not bad. Okay, we have here the supine Dale test. Look, it's not again maybe grade 2, and here Dale test maybe 5 to 10 degrees difference. So what to do is reconstruction. Now, you have many techniques. You will see many techniques in the literature. The most common was used is Larson technique, or you have this modification as zero modification, where here the both strand or both limbs of the ligament on common femoral tunnel, here different tunnel. So what we did, plan always, I do minimal invasive, but you can start with large incision and expose the peroneal nerve, pass the sutures, pass this the first limb under the iliotibial band, this one here in the femoral tunnel, in the fibular tunnel, again this under just medial to the biceps tendon, and this is important, the plane where you put the graft. You pass it, and here you have both limbs out, and you advance in the tunnel, and look, it's in the tunnel. Now you make tension. After that, you take range of motion, and always holding the sutures to know if it's giving or taking the suture. So it's the same tension. This is perfect, but you fix on the position where it gives, not it takes, because we don't want very tight ligament feeling of stiffness. Now this is the patient after. I'll go fast here. This is football player, ACL, LCL, pivot shift plus 3. Look the difference between the left side and the right side. So this is not significant, very significant instability, but this is athlete. He has ACL, we want to go ACL reconstruction, he has positive plus 3 pivot, so we decide to do what we have learned from our practice. Yeah, remember that case? So what we did, ACL reconstruction, LCL reconstruction versus repair, this was augmented repair, this was our plan, and a lateral extracapsular tendonitis. This is, you see, intra-op, after just testing the lateral collateral ligament, and this take range of motion, as I mentioned. It's good to have this electrically called. Now you see testing. Look how it was stable, and how now we relax rotation. This is the LET, and this is after fixation. What do you think about the result? Can this patient go back to sports? This is the result. You see, this is after passing the rehabilitation program and also the functional test, and this is very important. This was the best work in the season. So, alhamdulillah, we have to work hard, and the result was alhamdulillah. Now, this is another photo player, but look here, this is much different. Look the degree of instability the patient has. And he has ACL. Okay, look what happens. Open approach lateral wide. Because this is different injury, this is significant injury. What's the diagnosis here? Who knows? This is avulsion of all the sleeve of the biceps femoris and lateral collateral ligament. So this is complete avulsion. So in this case, repair or augmented repair? Augmented repair. So we have done that. You see here testing. We put our graft, augmentation by graft, because this is athlete. And we fix here the anchor for fixation, the fibular head, and you see it's holding the graft for augmentation, and we did ACL, and after ACL, we tensioned the graft, and we did final tensioning of the graft, of the ACL. And look here, it's stable, follow up the lateral and the ACL. And the result, do you think this was maybe part of like knee dislocation? Do you think he will go back later? Yeah, after functioning test. This is the result again. You see, you got a goal, yeah, very nice goal. And actually, frankly, I told him that you may not go back to play in the same pre-injury athletic level. But fortunately, alhamdulillah, he could. Now, more complex case. This is one of the cases I have learned from, because this patient had 4 ligament knee dislocation, presented to me after only the surgeon did ACL. I did double bundle PCL, MCL, and also lateral collateral ligament, and in later stage high tibial osteotomy, and all that, look, still she has thrust. Why? I took her to the theater and make the lateral anatomic technique. Here, look to the stencil view, the medial side is okay, the lateral is open, with the double bundle anatomic. And this is, I have learned, in cases of this degree of instability, when we have other ligaments injury, I think this is the best technique you can do for your patient. And this, we have learned from that the rule of early proper treatment, like take this case, for example, this case, 4 ligament knee injury, 4 ligament tear, posterior knee dislocation, patellar fracture. When we treat him early by augmented repair of all the ligament, look, the MCL, the lateral, even the ACL, we have repaired the ACL was avulsed from the tibia. So we did, the PCL was beyond repair. We did just bracing by fiber tape. And look here, this is the brace for the PCL. And here the result, you see? Now here, there. And the after X-ray, he has some subluxation, and we expect that posterior translation. And look, only with that, earlier post-op rehab, 8 months, stable knee, stable MCL, stable ACL, stable ACL, some like laxity on posterior drawer test, and here after 14 months. And we canceled the plan for PCR reconstruction. It's doing good. So, if we go back to this case, sure, you agree that we have to do something for the MCL to go for ACL, choosing the graft from the other side, and do bracing of the MCL. So by conclusion, collateral ligaments are part of a capsular ligamentous complex structure. Other associated injuries are common, which must be looked for and treated. Conservative treatment is the gold standard for low-grade injury, and when there is no associated other ligament injuries. Acute repair should be considered, and augmented repair should be considered, because this will lead to less later residual laxity, and augmented repair has a benefit over just repair, and reconstruction is used in chronic setting with a numerous variation in the techniques, and don't miss the coronal malalignment. Thank you.
Thank you, Dr. Asad, and now we'll just to the panel